Welcome to everybody. Thank you all for coming. This is our last event of the 24-25 season. And we really welcome everybody who came. AAUW is the leading provider of support for women's education, secondary education, and the AAUW in Middlebury, which is the Middlebury branch, I'm the president, has been, now I always have to look it up. Well, it's over 100 years old. Mary, can you turn the lights down? No, aim them.
No, I can't aim them differently.
Okay, because.
If they bother Kelly, I will turn it down more.
Okay, all right.
You're a star, Diana.
Oh, yeah. So we have monthly meetings from September to May, and at the beginning and the end, in September and May, we have their potluck at people's homes. The rest of the time, we have public events almost every month. We try to have every month. And if you have any ideas for topics or you would like us to pursue, or people that you would like to see here present, please let me know. We have a fundraiser every year, a raffle, which raises it's the only fundraiser we have, and it raises money for women's secondary education. And we give awards to high school students for excellence in languages, science, and the arts. And we have a fourth one. I meant to write that down. And we also support Afghan students attending Middlebury College. And to support them at the moment, we need host families in Middlebury and in Boston and Waltham, Mass. for the summer to support the students who have internships in those places, so they're not the full summer. So if you can help, or you know somebody who can, please see me or Leanne after the presentation. And the presenter tonight, now I get to look at my notes, is Kelly Macauley from Northern Arizona University, and she's going to talk about the uses of simulation in healthcare. And Marion, are you going to do the honors? Step carefully.
I brought support. There. Come on over and I'll introduce you. Some of you may have seen the write-up in the Addison Independent, but for those who haven't, I'll just review it very quickly for you. Dr. Macauley is a clinical professor and director of curriculum at Northern Arizona University. She graduated with a BA from Williams College, received her DPT, Doctor of Professional Therapy, Physical Therapy, from MGH, Institute of Health Professions, and Doctor of Education in Educational Leadership with a specialization in educational technology. Her clinical practice is primarily acute care and in rehab settings, specializing in care of intensive care units. She is an American Board of Physical Therapists Specialists in both geriatric physical therapy and cardiovascular and pulmonary physical therapy. She received formal simulation training at the Center for Medical Simulation in Boston, and is also a certified healthcare simulation educator from the Society of Simulation. She was previously the director of simulation at Husson University. She has served on or led several national task forces and panels related to simulation for the American Council of Academic Physical Therapists. Dr. Macaulay's research interests include simulation and optimizing educational learning strategies. And she has multiple publications in both. And we have links for anyone who would like to follow through. So without further ado, I introduce you to my niece, Kelly Macauley.
Well, thank you for that lovely introduction, and I'm thrilled to be here to talk about healthcare simulation, which is a passion of mine, and an educational modality that I think is really exciting. Is anyone familiar with simulation, or have you heard about it at all? A little bit, but for the most part, no. That's what I assume, so I want to make sure we're at the right level here. Before I move on, I just want to, this picture here is a type of simulation. It's a traditional sort of skills lab, and you can see there's a few concepts that I just want to highlight. And some of those are, you can see there's hospital beds there, and that's an important concept when we're talking about simulation, to try to make it look as realistic as possible for when we're transitioning from an educational setting to a clinical area. And you can see areas where students can work together. You can see monitors, and there's even mannequins in the beds. And the mannequins can be pretty complex and very expensive, and I'll talk about those in a little bit to explain the kind of things that they can do. All right, let's see if this works for us. I have no disclosures, financial or other, to report, other than I'm here at the request of my aunt. I think Marion hit on most of these things. The one thing I will explain is I do work at Northern Arizona University, but I do live in Scarborough, Maine, which sort of probably seems like a disconnect. We have a hybrid physical therapy program, which means a lot of it occurs online. So we do a lot of the didactic learning, online, and we have our students all over the country. But then a couple of times each semester, we go out where they can practice the hands-on skills. So I travel out to Arizona, either to Flagstaff or Phoenix, a couple of times a year, but otherwise I do a lot of that online. So that allows me to live in Maine, but also work in Arizona. All right, so what I'd like to talk a little bit about today is just to give you a brief history of where simulation started, and to help familiarize you with some of the terms within simulation and what it looks like for students to engage in simulation activities. So what I'm going to start with is just defining what simulation is, so that we're all on the same page when we're thinking about it. A few years back, the Society for Simulation in Healthcare partnered with the Agency for Healthcare Quality and Research and created a dictionary for simulation. A lot of different professions were using simulation, and they were saying the same thing, but they were all using different terms, and it made it hard for us to communicate when nursing simulation was working with a physical therapist, was working with physicians. So they got together and created this dictionary that allows us all to speak the same language. So what we're talking about when we're defining simulation is it's a technique that creates a situation or an environment to allow persons to experience a representation of a real event. And it can be for learning, it can be for assessment, it can be just for the opportunity to work within a system. So in other words, we're putting learners in a situation that replicates what they need to do in everyday practice, but there's far less risk associated with it. So let's talk a little bit about the history of simulation. So as you can see from the two pictures here, there's two branches that contributed to what we now know as healthcare simulation. The first is the military. And military simulation has been around really for thousands of years. What it first looked like is where they would literally line up and act out warfare. And then that's progressed throughout the years. In the 1800s is when they really got to the point where they were having these organized sort of simulated games where they created them and used different rules and things like that. That has further progressed to what we can see here. Oh, I have a little, hang on. right here, where they literally will game out different strategies and things on the table. And this is before the advent of computers, obviously. And then here we have what modern day simulation looks like in the military, which is where people can be immersed in virtual reality environments, and they can actually practice in an environment that replicates what they will have to encounter when they're in battle or whatever the situation may be. The other place that we've seen simulation is in aviation. And that hasn't been obviously around quite as long as the military simulation. But even as in the early 1900s, they had like the first simulator that was like a barrel that they could go in that sort of simulated some of the movements. Of course, it's not even close to what we have today. And it was in the Depression that they had the first sort of flight simulator that was created. When the computers came around, and once we got to the 1970s or so, we had the more digital type simulations. And again, now they've progressed to where they're quite advanced, where you have movement, you have visual displays and things like that really replicate different types of situations. And the benefit in both of these contexts of a simulation is really to decrease mortality and decrease the cost associated with practicing. Because you can think of the risks associated, obviously, with practicing. Some of these are quite high. So now we'll move on to healthcare simulation. Healthcare simulation started, again, you can go way back to when they would use wax models and clay models and even skeletons. That's been going on for hundreds of years. But it wasn't really until the 1960s that healthcare simulation really grew. And I don't know, has anyone ever been certified for CPR? That's the original simulation. Resusci Annie is the original mannequin that was created in the 60s. And it really hasn't changed that much in recent years. It's still the same thing where you can practice your compressions, you can practice your breathing. But that was the first mannequin that was created. Around the same time in Norway or Sweden, one of the two. Lærdal created the first cardiopulmonary simulator, which allowed healthcare professionals to practice listening to someone's breathing and heart sounds and to learn what those sounded like before they actually did it on a person. The thing that's really interesting is we had that technology even back in the late 60s, but it really wasn't utilized very much. It sort of died, and it really wasn't incorporated into education until the early 2000s. And the reason that it had a huge increase at that time is because there was a huge increase in medical errors and a huge increase in mortality that could have been prevented. And simulation was identified as one of the modalities that could help decrease the mortality rates of these preventable things. They found that a lot of the issues that were occurring, that were leading to higher increased risks of death, were poor communication and teamwork and team building skills, and ability to sort of navigate the hierarchy that existed at the time within the medical system. People would notice that something was going wrong, but they wouldn't speak up. Or sometimes the person at the top of the chain may not listen to the other people who were giving information. So there was a problem within our healthcare system that sort of created these issues, and patients were getting harmed. So it was at that time that CMS sort of put out a hallmark paper and kind of call that we need to change these things, and we had to start it from the education. And people recognized that simulation could do that. It would allow for real-world practice without harming people. So that's where, in the early 2000s, we saw a huge rise in simulation, and now it's part of almost all healthcare professions training, both from an interprofessional perspective, so working on teamwork skills and building and communicating and things like that, but also working on individual skills within each profession. It started with medical education, but nursing education is usually very quick to follow medical education. So we saw a huge increase then. And then slowly we've seen the other health professions, physical therapy, pharmacy, occupational therapy, even like midwifery, dentists, have all started to incorporate simulation into their education programs now. Around that 2000 time, we also saw some groups that were establishing best practices for creating simulation. Simulation actually follows some very strict rules that are taken from educational pedagogy to actually help to structure the learning experiences so that people can get as much, the learners can come out achieving the outcomes that we want them to achieve. And we had a group within nursing, the Society for Simulation in Healthcare, which is mostly physician-driven. And then there was a third group, which was the Association of Standardized Patient Educators. And standardized patients are people, like any of you, who are trained to play a patient within a simulation. And so they came up with some best practices as well, and I'll talk a little bit more about those later. Any questions? I forgot to tell you, if you have any questions, please feel free to stop me at any time. So what's the purpose of simulation? Well, there's several good benefits to simulation. The first one really, and this was, as I said, the push for using simulation more, was patient safety and really maximizing patient safety regardless of the context. It really can help to have this deliberate practice to improve communication between professionals. The other thing that it can really help is allowing people to practice high-risk, low-frequency skills. So what we mean by that are something where the risk to the person is really high, so the people might be really sick, or it's a really hard procedure to do, but you don't see it that many times in the clinic. So it may be several years. You may see it once and you don't see it again for several years. So you don't have a lot of time to build up repetitions to be able to successfully complete that skill. In a simulation lab, we can create that and you can do it over and over again until you master it. So when it does come up at that random time in the clinic, it's like, boom, you know exactly how to do it, you know exactly what the procedure is. And again, it helps to increase patient safety from that standpoint. Excuse me. Another key concept of simulation is this concept of deliberate practice, where you can go through, you can do something, try it, you get feedback, which is a key component of simulation, and then you try it again. Get feedback, try it again. Again, it allows you to master these skills. It allows us to standardize the experience, so we know if I have a whole class, say you're all in my class, and I have you go through and you practice a skill, by the end I can say, you all know how to do this skill. And I can feel comfortable sending you out to the clinic because you've had that level of practice and you've demonstrated mastery of it, which is really important. The last piece, and I'll talk about this a little bit more, is the guided reflection that occurs during the debriefing process. And I'll circle back to that in a bit. So what does simulation look like? So let's say that you are all going to participate in a simulation. What will that look like for you? So it starts off with pre-work. Pre-work is essentially the work that you need to do before you come into the simulation to set you up to be successful through the simulation. Let's use the example of CPR. What you would do as your pre-work is you'd have to learn, okay, I need to do this many reps if it's an adult, I need to do this many reps if it's a child, and I need to do, and this is the procedure that you do it, this is how long that you do it. And you would study that information before you came in. It could be that maybe you're a nurse who's learning how to put in an IV. So you would study the steps that it takes for you to do that before you come in. So you do whatever the students or learners do whatever it is they need to prepare for whatever the objectives are for that simulation. It may be just reviewing a case. Maybe you're going to come in and do an interview of a patient or something like that. So they have to read through the patient chart. And so that's their preparation. But there's something that helps to prepare them to be successful for the experience. Then anyone who's participating in the simulation comes in. And we do what's called a pre-brief. This is to orient all the folks to everything that they may be exposed to in the simulation. If we're in a room that's like a hospital room, I might show them how to use the monitor. Like, which buttons do we push? You know, if they have to operate the hospital bed, I'll show them how to raise the head up and down. That confuses students more than you would believe, is how to operate a hospital bed. It's all those little things just to make sure that they can concentrate on their performance of whatever the skills are that you're looking to have happen in the simulation. Because you want that to be the highlight versus they got tripped up because they don't know how to put on the blood pressure cuff or, you know, move the bed or whatever it is. So after we do the pre-brief, the students go through an encounter. And that's the simulation itself. And it may be one student with a mannequin or a person. It may be a couple of students working together. Oftentimes, especially with new students, that's a very good strategy because they can sort of help each other through that. So you'll have some subset of students who are actually doing whatever it is that the objectives of the scenario call for. And then you'll have a faculty facilitator who's watching that, sort of taking notes and looking at their performance. And then you also have a subset of learners who are actually watching the encounter. Those learners, the literature has shown us that the observers can have the same learning outcomes if it's set up correctly as those who are participating. They can identify with the people, with their colleagues that are actually doing the encounter, and if you give them different prompts to think about, they can give great feedback to the other students because they can imagine themselves actually in their shoes. So we have the people performing and then the rest of us sort of observing, and usually by camera, not usually directly in the room so that they don't know that we're there. It's actually helpful because otherwise they remember that there's people watching, and if they usually get to the point where they forget that there's cameras there, usually. Then we have the debriefing, and as I mentioned, that's actually one of the most important parts, and what it is a guided reflection of what happened during the encounter. Oftentimes, we have learning outcomes for the simulation that we want the students to meet. What we're doing in the debriefing is looking at what their performance was and looking at what those outcomes are and addressing any gaps and saying, gosh, I really expected you to take the person's blood pressure before you helped them get up out of bed, but you didn't do that, and then they got really dizzy and fell down. So let's talk about your decision making during that process. And you help the students explore why did they make those decisions. And the goal is for them to identify, maybe that wasn't the best decision, they should probably do something different next time. And that's what the debriefing is. And that can come from a facilitator, it can come from their colleagues in the group, and sometimes it comes from them in their own reflections, walking in and being like, I can't believe I forgot to do X, Y, and Z. So, but it's that guided opportunity for reflection and feedback where all the learning really occurs. In some cases, we might have them go right back in the room and do it again. Because they've gotten the feedback, now we want them to change their behavior and really cement that learning. Sometimes because of time and things like that, we're not able to do that, but that's an ideal next step. Then we have them do an independent reflection oftentimes to really think about their performance later, and what steps might they take to do something different. So we can repeat this process for all sorts of learning objectives to help folks be able to perform better in the future. Let's skip over that, we talked about that. So one of the things that's extremely important when you're talking about simulation is creating an environment that feels psychologically safe to everyone that's participating. You can't have people in the simulation who are worried about, oh, I'm going to get this wrong, or I'm going to lose points, or I don't know what Susie's going to say. You have to create an environment where everyone just makes an assumption that everyone's doing the best they can, and they're there to learn. And it really incorporates 4 different types of safety that we need to be cognitive of. One is the learner's safety, so that they feel like they can go out, try their best, and they're not going to be judged, that they're just there to learn and to grow. We have a challenger safety, so folks should feel like if there are people that are watching a simulation, they should feel empowered to be able to ask questions or to ask the people that were participating, gosh, why did you do that, Susie? I would have made a different decision. Then we have the contributor safety, which allows people to contribute their ideas and their perspectives. Gosh, I think I might have done it this way, or I might have done that. And then inclusion safety is to remember that everyone brings in their own experiences, and that may explain or really explain how they would react in a certain situation. For example, if I've seen it a lot when there's you're doing a simulation with children, and people have been through an experience with a child, or if they're a parent, it's hard for them to separate themselves from seeing their own child in that situation. So trying to create an environment where everyone feels that they can really put themselves out there and then learn from any mistakes that they may make. Another piece is extremely important when we think about simulation is fidelity. And the definition of fidelity is the degree to which the simulation actually replicates the real event or the workplace. And there's a couple of different types of fidelity. One is physical, which really talks about the environment. So does the room that they're in look like it would in a hospital? So that first slide I showed you where there was hospital beds, there was a monitor, things like that, that replicated what it might look like on a hospital ward pretty closely. And there's even rooms that are a little bit better, and I'll show you a couple pictures. Even this one here, you can see like the board across the top has the blood pressure cuff, and it's got the otoscope and things like that you would normally have like in a hospital room. You have the patient who's got oxygen on, they're in a Johnny, so the patient looks like they would if they were in the hospital. Even the folks that are participating are wearing those yellow gowns that you would wear if someone had specific resistant organisms. And even that's important because when you're wearing those and you're working with a patient in a hospital, you get tremendously hot. So that's creating an environment that really is going to replicate what they would do if they were in that hospital room just like that. So those are all ways to create a physical environment that's going to replicate what they look like, their real work would look like. This part is conceptual fidelity. Conceptual fidelity is really this concept of could this actually happen? Or does this patient really exist? I think sometimes people are like, I've got one shot and I've got to create a case, and they put all these things in there that would literally never happen to a person. They get hit by a bus, then they get, whatever, these things that become so ornate that it would literally never happen to one person. So we need to create situations that really would happen so that it becomes believable for the participants who are in there. And the last part is an emotional, experiential, or psychological fidelity. And that is, it emits emotions that the person would likely feel if they're in that situation. So it could be something where it's fearful. So if you have a patient who codes and you have to initiate CPR, that's an adrenaline rush if that happens. So that's a type of psychological fidelity. Another type might be if it's, you're dealing with someone who's at their end of life and you're having that conversation, which is a very difficult conversation to have between a caregiver and a patient. That creates an emotional response. So that's a different type of fidelity that we can have. And in a simulation, it's most likely all of these are not going to be optimized. You're usually going to sacrifice one or another and sort of modulate them depending upon what the objectives are, or in other words, what do you want the students to get out of the experience? But they're very important things to consider, and you recognize that, okay, I really want the physical environment to really be like it's going to be in the clinic, but I might use a student as a patient, versus in this situation we have someone who really looks like an older adult who would be in the hospital. So that might be an example where we sacrifice one for another. So there's a lot of different modalities we can use for simulation. One of the most basic ones is a paper-based. So you can have a case that's just on paper and people talk about it. That's really the lowest level and got the least amount of flair to it. The next level that can be especially important and that I use a lot in physical therapy is a human actor-based simulation. And that's where I train people to play the role of the patient. In physical therapy or occupational therapy, it's really helpful because our professions are so tied to movement. It's really hard to move a mannequin because they're about 85 pounds and they're really stiff plastic. So it's a lot more helpful to use a standardized patient who I train to pretend that they had a stroke, and I can train them to act that way so that my students have to help to move that person and interact with them as they would with someone who had a stroke. Simulation, actor-based simulations are also really helpful when you have to work on communication. And that's the goal of the simulation, because you actually have a real person talking back to you. We can talk through mannequins and we can be sort of the voice. It's actually a little creepy for the most part for the students because all of a sudden they hear a voice and they're not, and it's clear that the mannequin's mouth is not moving. So it makes it, we've sacrificed fidelity for that of the communication by doing that. So if my goal of the simulation is really to work on communication, then I'm going to use a real person and not use the plastic person. A couple other modalities we have, whoopsie. One's computer-based, and this is really good for, they're literally working through a case on a screen. And this is really good to sort of get their cognitive processes down and their decision-making and sort of reasoning about a patient. And they can click through, in the example on the right there, the person's actually can, and now with more advanced technology, they can actually talk back and forth with them, and it allows them to, again, practice potentially interviewing a patient, or here they might select different tests and things and then get the results right on the screen. So it allows them to practice their decision-making and to get real-time feedback, but again, the risk to a patient on a computer screen is obviously very low. The next type that's getting a little bit more complicated is task trainers. And these are where you're working on a really specific skill. And this allows, again, that deliberate practice, repetition. If we look at the picture up here, this is actually a sort of a joystick and a simulation that a surgeon might use to practice like a minimally invasive surgery. And it allows them to do that, visualizing what they would see on the computer screen, but manipulating with their hands what they would do for that procedure. So again, they can do it several hundred times before they actually do it on a person and get that practice under their belt. Similarly, this is someone doing an ultrasound, so they can practice positioning the patient and finding the right area and the amount of pressure that they need to give and looking at the computer screen. This is our modern day Resusci Annie that you all use for your CPR. The modern day one is actually really cool because it will tell you how deep you're pressing down on the chest and say, okay, I can say, Johnny, you need to push a little harder. You're not going deep enough to be effective. Or it tells us the rate, so I can say, got to be a little faster. So we can get that real-time feedback. But again, as you can see, it's just something that's created a mannequin for that task. And only that task, because it's just the chest and the head, so you can practice doing like the breathing component as well. And there's also task trainers that actually feel like real skin, that allow phlebotomists, nurses, doctors to practice doing IVs and putting those in. And we can just, after it's had so many punctures, we can just take the skin off, give it some new skin, and they'll be right back and we can just replace the blood and all of those things. But again, it gives them that practice so that they've had those reps, again, before they're using your arm to actually get blood. Yeah. And these are our most high-level mannequins. So these are all mannequins. And look at, like, if you look at the face and the skin here and over here, the things that they can do with the technology now is so lifelike. And they can do, we certainly have a lot of infant things that they can practice. We have people of different sizes, colors, things like that. So again, it replicates what clinicians will see in practice. And these go anywhere from, that you might be able to get something that's just a mannequin where you can take blood pressure or something like that. It's probably, about $15,000, up to, like, this is Noelle here, where it's a maternity mannequin where you can practice all sorts of complications and that could happen in the birth and delivery process. And she runs about $100,000. So these things, they're very expensive, but if you think about the benefit that you get from that repetitive practice and the decreased risk to mom and baby that all labor and delivery nurses and what have you have gone through, obviously the benefit's far greater than the upfront costs. What we're really getting into now is the virtual reality and augmented reality environments. And in virtual reality, what it allows you to do, you have the computer technology to create an interactive sort of three-dimensional world that you can usually either interact with the patient. In most cases, you can interact with the patient, and you can, it gives you a different sense of your sense of space. You can have augmented reality, which actually almost puts you and superimposes you within the environment. And there's usually some sort of haptic controls where you can actually feel things through the controls and feel what it would actually be like to be in those different scenarios. And those are things that are becoming very accessible now. So just a summary of those and what we would do from an educational perspective. So if we're using a mannequin, oftentimes it's for something for a critical care that we wouldn't want to do on a real person. So maybe a code or something like that where we would want to practice chest compressions, all of those things, but put in IVs, but we don't want to do that. You don't get a lot of volunteers for that, per se. Standardized patients, like I said, that's something where communication, when you're working on communication skills or decision making, or when movement's important. The virtual and augmentative reality are really helpful if you're trying to really immerse them in what a scenario's like. You can put them in the operating room. You can put them in a busy ER ward so they get all the noises and sounds that are happening so they understand what that stress can feel like. Screen-based, as I said, is really more for cognitive training and to help them learn through those processes. And then the interprofessional and team-based simulations are really focusing on communication, leadership, and teamwork type skills. The next area that was really growing and taking off is how do we layer artificial intelligence onto simulation? And there's so many different ways to do this. We have mannequins now that I can just start talking to and they can talk right back to you. And they do it by artificial intelligence. I mean, I can use, I'm sure you've all heard of ChatGPT. I can put in a small case into ChatGPT and say, pretend you're a patient who came in with a shoulder injury, you have diabetes, a couple of sentences, and I can have my students do a full interview just with the computer now, with the artificial intelligence answering the student based on what they've asked. It's amazing. And we can also, creating good simulations is a lot of work. There's a lot of education, like to create a good scenario, to create all that pre-work, to create the case. All of that takes a lot of work. We can use AI to do that work now. Like we can say, this is what I want my case to be, and boom, it'll create everything, and you just have to modify it. So it's really streamlining the process of simulation, but it's going to be really exciting, and it's a little scary to see where that goes. So there's a lot of ways that we can deliver simulation. A lot of the things that I've shown you so far, I've been in a simulation lab where you have it set up and it looks like the simulation. You can do it in a classroom. It's usually a lower fidelity simulation, but it's a very effective way. We can do it virtually, and we could do it over Zoom, for example, where maybe you're having a telehealth visit or doing an interview or something like that. Another way we can do it is in situ, which means a lot of times larger hospital systems will dedicate like an OR or a clinical area that is just for simulation practice. Because I've been talking a lot about simulation for students. It's used a lot for existing teams as well. And having it right in a clinical space makes it a lot easier for busy clinicians to jump in, participate in a simulation, get the learning benefits, and then jump back out to training their patients. And the one I don't have on here is mobile simulation. They have kind of large trucks that have like simulation units inside of them. And the best place I can think of where they've used it is in rural Canada, where they're very expensive to create simulation centers, but this allows you to travel with the simulation unit, so you can go to different hospital systems and have the experience, but without having independent structures it's difficult for the clinicians to travel to. So in rural areas, that works really well. So we know there's great benefits to simulation. It increases self-efficacy or confidence in the learners who participate. It really helps with their clinical reasoning skills and their ability to make decisions, their ability to make the right decision in shorter amount of time. It really helps with interprofessional IPs, interprofessional education, but it helps advancing at the educational level. But then if we're talking about for existing professionals, it really helps in their communication skills and building teamwork. And we've seen a huge decrease in those errors that were happening 25 years ago because of the influence of simulation. And it also can help with knowledge. So we talked about those task trainers where you're practicing things repeatedly. They can learn things via that rote memory so that they don't have to think about it when they're in the clinical situation. Oh, thanks. I guess I'm at the end. Do you have any questions or any comments? Yeah.
The AI, and I'm sorry to address it, but the effectiveness of the AI is how much you give to what's the situation, so that then build.
100%, yeah, because the AI learns from itself based on its previous experiences. So depending upon how much information you give it, and you may have to tweak it and be like, oh, I want you to be more vague, like something like that if you're trying to create something. And part of it is we can create, I can give prompts to my students, so put this into ChatGPT, these are the prompts that I want you to use, so I know it's setting it up appropriately. However, because AI is generative, it changes every time. So it's going to be different every time. There are ways, like different programs that you can use to create something so it's a little bit more static versus just using like a large language model like ChatGPT.
Would you review that?
Of course.
You want to make sure that it's coming across.
Absolutely. Or I have them do that when I don't care if there's a little bit of variability. So if it were a testing situation, I probably wouldn't use that method because there is that variability. But if it's just for them to practice doing an interview, if the person goes a little wonky, that's okay, because that actually happens in real life. They don't know. So like, that variability is really okay. Yeah, but it's super exciting. The mannequins right now that can interact just like you and I are talking are pretty rudimentary in terms of their technology, but I mean even probably in a year they're going to be so much more advanced and it's going to be just like a normal conversation. It's going to be really cool.
And those patients react like a real patient. They're screaming, they're panicky, they're not listening, they're so forth.
Yeah, and we can do that we can either train people to do that, and I've done that, or we can do that through a mannequin. But as I said, it sounds a little creepy because it's like a voice from above if you're trying to do that. But that's the type of environment that we want to create. That's that emotional fidelity or psychological fidelity, because that's really scary when that happens and you're a clinician. If a patient's sort of freaking out or getting excited for some reason, and how do you de-escalate that? That's a great simulation to put them into. Yeah.
Would medical schools have multiple simulation labs?
Usually,
like
yeah.
A pediatric one or, a geriatric one?
Yeah, 100%. Like they usually have to go through for, I know at because I work in Arizona, for northern Arizona, but the simulation lab I work in now is with the University of Arizona and Arizona State, because they're all three of the state schools. So they have a series of simulations that all of their medical students need to go through. So they will do one that's pediatric, geriatric, this, like all the different systems that they have to go through in practice. And the thing that, usually you can use the same space, but you may switch out the mannequin, or the case is what shifts. But oftentimes you can get away with using, you can have like an inpatient type space that sort of looks like a hospital, and then a space that's an outpatient that sort of looks like when you go to your normal outpatient. If you have those two spaces, you can manipulate what you put in the space to get at all those different areas. And it helps you to save some money.
When I think of the, old movies where the doctor did rounds, does it eliminate some of that?
It can a little bit. I think it's still, you still have to have that, but I think they can be quicker. Because one of the simulations that I've done, with my students is actually simulating rounds. So you can be more efficient and you can practice, okay, this is the information I need to give. So we still need to talk about the patients, but how we do it looks different. And I can graduate clinicians who are much more efficient at it, so it happens in 10 minutes instead of an hour and a half, So I think it does help, but I'm not sure it eliminates it necessarily.
How does it work for surgery?
It's really interesting. They usually have the different, it depends, like the actual instruments, and it's usually attached to types of computers where they can actually manipulate and actually practice with the surgical tools. I'm sorry?
Like a robot?
It can be, and it's just like, or it could be like the picture I have there where, some of these minimally invasive surgeries are very small instruments that they're manipulating. So they just can practice using those and then see on a screen. Or it could be something where you're actually doing the surgery on what I was calling a task trainer. So if you're doing abdominal surgery, maybe it's just an abdomen with tissue that feels like it would be normal, and they can go in and practice doing that.
Is there blood involved?
Oftentimes, yeah. Oftentimes, because one of the things, because oftentimes, bless you, what you want to practice is what happens, like you reacting when something goes wrong. So they'll have arteries that will have veins, and that there are arteries that if you nick them, yeah, there's going to be blood, and the cavity fills with blood, because you need to now know, I need to suction and clean this up, or what do I do next? So those situations, and I know that's something they usually do with the labor and delivery, is like hemorrhaging is an important part of managing someone, in that situation. So how do you, and that one's really messy. You can usually only do that once a day, because there's I do a lot of shopping at the party store where you can get the fake blood. It actually comes through. Usually I go to their after Halloween sale and stock up for the year. You can get it on a quite discount. Some of the things that you learn. I saw a couple hands over here.
I was wondering how universal is this throughout the...
It's pretty standard. In medical school, nursing school, it's completely standard. In nursing, they've allocated up to 50% of their clinical education time can be in the simulation lab, because they've separated out skills that are procedural, that you can practice in the simulation lab, versus things that you actually have to be in the clinic to learn. So it can be substituted to that amount. And something like medical school, a lot of times they use it like pre-clinically to get them ready so they're in a better state when they get into the clinic. And then the goal is that they're more efficient. The one piece that's lacking in the literature right now is looking at that translation. Are we really taking people and moving them? How much further are they moving, and how much is it actually impacting the medical system as a whole? We know it helps individual learners, but from that systemic level, that's the part that it's really hard to measure, so we don't have great data on that.
So is it part of the accreditation now?
In most cases in medical school and nursing school, it is part of accreditation. In occupation and pharmacy, it is part of their accreditation. Physical therapy is silent on it right now. That is actually not part of the accreditation, but they recognize it as a teaching modality to help prepare learners better.
What about veterinary?
That's a really interesting, I was having a conversation with a colleague of mine about that. I do think they use it to an extent, but I'm not sure to what extent. I mean, it certainly is right for, it would translate the same way, it would just obviously be different innings. Then, you know, a horse is a little different than a person. Yeah, I know, yeah. You don't want to be like, wait a minute, something's different here. Yeah, but the skills and the work, the things that you need to do, I mean, obviously the communication skills and things that we use, you know, for healthcare simulation doesn't translate as much, but those task training skills certainly would.
There's a whole lot of literature about the bias in medical behavior.
Yep.
Can you put some of that into simulation and make people aware
Yep.
of?
Yeah, 100%. Simulation is a great way to sort of, especially those unconscious bias. And I think that's where the bias is coming out. So yeah, that's where a really careful case design is important, because you're going to embed things in there to sort of highlight potentially someone's unconscious bias. It may also highlight someone who doesn't have or is aware of some of their biases and how they navigate it, so it can also be an exemplar for other people who are watching to see how to handle it, and they can reflect on what their biases may be. But that's a great way to use simulation.
Are you talking about a professional bias or a bias between culture?
It could be
Professional
both.
bias between doctors and nurses.
Yeah.
Holidays is huge.
100%, yeah.
That definitely needs to be taught to students, that is out there, and they need to know how to deal with it. Is that something that you do?
Yeah, 100%.
Good.
And that was one of the reasons, those biases, is one of the reasons 25 years ago that all those medical errors were happening.
Yeah, exactly.
And so there's been a lot of targeted education against that professional biases or perceived hierarchies and mismatches. But there may be other biases that exist that people have, whether it's race, gender, whatever it is, that you can embed in cases and really bring out as well. It's a great way to do that, and even to set up the conversation to help people increase their awarenesses, again, of what their biases are.
How does AI handle that?
That's a great question, and I have no idea. I would
I
imagine,
can't say that because that's the truth.
yeah, no, and I would imagine there's bias within AI. You know,
They're just,
I mean, it's just generating from everything that's
They
been
are
out there.
learning, so
Right.
should they perhaps learn the bias?
Yeah.
That would be an interesting paper.
100%, yeah. Not that you don't know. But it is interesting. That's not something I think that's out there yet, but I think that it's because it's regenerative based on that input, that it's going to be prone to bias, for sure.
suspect the volunteer side of it, talk about costs or
It,
something to balance it out.
Yeah, it really is, and there's ways to be. You see a lot of people partnering. So you have medical centers partnering with a medical school, a nursing school, other health professions using one center versus the medical school has its own simulation lab. Or, like, I think that it was originally set up like that, but I think those sort of barriers are, because of cost, are being streamlined a bit. Or there may be a regional simulation center. I was working in a school in Minnesota, and we had like a huge regional simulation center that worked for multiple universities in the area. So then they're busy all the time, because sometimes if you have smaller schools, they're maybe only using it some of the time, which really is not a cost-effective way, because these things are so specialized. And the training, I mean, we were talking before going back here about, you almost need, like when I was a director at the simulation lab, you had me as the educator, that I brought my knowledge, but I had someone who specialized in computers and networking, because these things are getting so technologically advanced. So like you need different members of the team with all those pieces of expertise in order to make the lab run effectively. Yeah.
Can you go back to that slide which you called Institute? There was, it looked like somebody was working with an actual human being, although I don't know if her. Yeah, that one.
Oh, this one?
No, that was.
Yeah, that is a real person. So this was this is an example of a virtual simulation where one person is actually working with a standardized patient, and then on the side you have 4 or 5 other people watching it. So they're watching what this person's doing and taking notes and whatever, and then after this person completes whatever their task was, we have a discussion and debrief where those observers would participate in that and say, oh, really, you should have put, your hands here, or I wouldn't have put their socks on until they were sitting on the edge of that, whatever it is. They can give feedback, or, I would have stopped their oxygen, it's only 93%, I would have put oxygen on them, something like that. Like they can watch that and be active learners, but actually not doing the activity. Yeah.
Could you talk a little bit about the volunteer actors?
Yeah.
And their training?
Yeah.
And what goes into standardizing a person?
Yeah, in most places will have a program where they have someone that's in charge of training and sort of wrangling people in. And when we do that, we create a case that's written for the actor, saying these are the things that I need you to remember and to act out for this patient. So and once you learn a case, it's actually really helpful to have the same people involved, because then you don't have to relearn the case. But we can teach you to do all sorts of things, like have like one side of your body be a little bit weaker, or to have, maybe you have difficulty speaking, and we can teach you ways to do that. And in most cases, they're actually paid. Like we pay our patients, it's usually, which is nice. But I've also done it where I've had volunteers who've done it. But we usually, spend time, an hour or two before any sort of like simulation, so that the patients feel comfortable doing it. And again, once you've done it a few times, then you get more comfortable. But most medical schools, nursing schools, or health profession schools are always looking for people to do that. And it's actually a really great way. I found that folks who are retired healthcare professionals are really great to do that, because they know what it looks like already, and retired teachers, because they're very good at giving feedback. Like they're used to, and if you get the combination of both those, that's fantastic. But those are and actors I've used a lot, like where I've had, like I've gone to colleges for theater groups and things like that, because they're used to acting and being in a different role. Those are the groups that I found that have been good, that really seamlessly fall into that. But it's a great thing, and we even use people, because my program's hybrid, we use people who can just jump on Zoom and can act a patient over Zoom, and so our students can practice interviewing and asking questions or things like that.
Kelly, do you have a company that is doing this so that you have people doing part of it and somebody else doing another part of it? Tell us about your job and your career.
So for what I do, I'm lucky now, because in the role I have now, I can just go to the sim lab and say, this is what I'd like to do. And then those people help me. In the past, I was responsible for spearheading all of that. So someone would come to me and be like, I want to do a simulation, and these are the objectives that I have. This is what I want the students to get out of the activity. So then I would help them create a case that has certain things embedded in them that brings out those objectives. And then we would go through and create that. Then we'd make sure we have all the equipment that we need. We create the space, that they need it to be in, and all of that piece. Oftentimes there's other technology involved, because we often record these and pieces like that, so we set up all of that in the background. If we need patients, we would train them to do that. So I'm involved in a lot of those things, depending upon what's needed, for the activity that I'm looking to do. But I'm really fortunate now that I've got a standardized patient trainer, through my university that takes on that part. I have another person that is the manager of the sim lab, so I just say I need 8 rooms, this is the equipment and I need in it, and I just show up and it's there. So I'm very spoiled now, and I used to have to manage all of those things myself.
How did you get into it?
It was when I first started teaching, I had a mentor of mine who was like, I think you'd really be interested in this. And she sent me off to the training. And I was like, wow, this is really cool. Because I was so interested in, I'm really a proponent of active learning versus passive learning. So how can we get people involved? And in thinking about how can we most efficiently train are healthcare providers. And actually having them practice getting deliberate feedback is the most efficient way to train them, so that when they step out and they're in the clinic, I know I've already seen them do these things, so I can feel comfortable sending them out. So from that perspective, it was really interesting to me, versus sitting up and talking at them. Like, how can I make it more real world for them? So that's
Were
what
you teaching in the medical school?
I have taught with medical students, but not for a while. When I was in Boston, I worked with Harvard med students a bunch, but more recently I've worked with nursing, physical, occupational therapy, speech therapy, pharmacy students. So I'm working with understanding like all of this, when I asked about accreditation earlier, understanding all of their, what they need to do for their license, as well as accreditation and graduation. So balancing all of those things to be able to meet whatever their needs were for their programs.
What were your undergraduate degree?
It was psychology with a concentration in math.
They go together.
They do.
not get that.
No, by the time you get to college and it's math, it's all about thinking and like being creative, which I really enjoy doing. It's like, okay, so we've got a problem, how are we going to solve that? So, yeah. So it was much different than what I'm doing now.
And it's fairly field.
Yeah. It was interesting, when I got my doctorate in education, I purposely chose the program because it had the specialization in educational technology. Because I saw that's where we were going, and and this is how we wanted to change. So that's why I chose that program, because I already had a little bit of a background in simulation. I'm like, yeah, this is where we need to go. And we need to think about how we're delivering higher education, and we need to think about doing that differently to be more effective and to reach more people. So, yeah.
Thank you.
Oh, glad you enjoyed it. Thank you so much for coming. Oh, thank you. Oh, can I help you?
No.
Go back to being a PT.
No, it's just a little bit higher. Now I have to get it out. We have a certificate of membership
Oh, thank you so much.
in AAUW,
Oh, fantastic. Thank you.
good for a year.
Okay. I have to come back again.
No, it's AAUW, not just us.
Okay. Oh, the national.
Right. So, thank you all for coming, and as I said, if you can help with the Afghan students, we would like to, let us know, and if you have ideas for events that you would like to hear or see, whatever, for next year, please let us know, and thank you for coming.
Thank you again.
Thank you.